Good morning, everybody. My case is about an interesting patient. It's not advancing. This was a 35-year-old man who was in otherwise good health. He complained of 3 episodes of amaurosis fugax in the left eye, typically concentric constriction of the visual field. First in April 2008, that lasted 5 minutes. It was diagnosed as ocular migraine when he was visiting Switzerland at that time. The second in July, which lasted a little longer. A third in August, which lasted further a little longer, and now had persistent diminished vision in the left eye. On clinical examination, he had this kind of a fundus picture in the left eye, which showed what looked like a branch retinal artery occlusion along the upper temporal arcade. The right eye was normal. The question was what to do next. We decided to go ahead with a fluorescein angiogram, and lo and behold, that was very revealing to us. What we thought was a branch retinal artery occlusion was indeed a central retinal artery occlusion, and the cilioretinal artery was what was filling up this aspect, this lower temporal aspect. And this patient actually had a CRAO. We immediately did a paracentesis. The role of FFA in CRAO, it helps detect so many things. Principally, in this particular kind of a situation, it helps us to delineate whether it was CRAO or BRAO. The OCT revealed hyperreflectivity of the superficial layers of the retina. Patient felt marginally better, and investigations that we normally do in central retinal artery occlusions were all non-contributory. Over the next 2 months, he had 2 similar episodes of visual obscurations. Patient and his dad were insisting on a paracentesis because he felt a lot better than that. We heeded to their advice and request and did paracentesis. The fundus signs had by then resolved, but we could not make out any obvious embolus that contributed to the visual improvement after each paracentesis that we were doing. So we decided to go ahead and investigate this because there was an episodic blurring that cleared with the paracentesis each time. We did a digital subtraction angiography based on the radiologist's advice as well. And lo and behold, we found an ophthalmic artery aneurysm in the first part of its course. This was the ophthalmic artery aneurysm that was detected on DSA, which we normally don't do in these kinds of patients. But because the history dictated that we identify a cause, we did DSA, and that was what we found. And that was the report which showed a dissecting fusiform aneurysm of the left ophthalmic artery aneurysm that was throwing up emboli. Now CRAO, the learning points from this case for me were CRAO may masquerade as BRAO in 2 situations: when there's a cilioretinal artery perfusing one aspect of the fundus, or if the patient had had a previous BRAO in another quadrant with nerve fiber layer atrophy that doesn't show ischemic whitening there. There are only two reports of an ophthalmic artery aneurysm causing CRAO, and our case adds to the literature. And DSA, by virtue of its higher resolution and ability to study the various phases of circulation, helps clinch the diagnosis when even an MRA may be inconclusive in such patients. Thank you very much for your patient hearing.
Good presentation.
Thank you, sir.
Thank you.